We are in room 2. I'm myself, Dr. Thiele, the director of the cath lab, and I have Josini, who is the associate director here, and then my 2 fellows as well as the entire cath lab team. So the first case we have, we can show the slides by the side, is an 85-year-old male who actually presented with angina class 3 and dyspnea on exertion. He did have a CTA which showed that he had probably moderate disease of the left main. Ongoing symptoms, he was referred to cardiac cath last week. So he had history of hypertension, hyperlipidemia, normally AFib status was ablation, and medication. I know a lot of discussion has happened on good medical therapy. So he's on statin as well as losartan for his hypertension. So cath, if you see here, I'm starting. He has a normal EF, normal EDP
we haven't
today.
seen the cath. Yeah, please.
Right coronary artery.
Okay, right.
Which is normal.
Quite normal for an 85-year-old. There we go.
Yeah. So significant distal left main, which is bifurcating into 95% ostial LAD and involvement of the circumflex. TV2 flow in the LAD. This is a guide shot where you can see distal left main and angulated takeoff of the LAD with significant disease and ostial circumflex disease also.
Wow. Incredible. So this would be a case that would be included in the Excel trial. No question about it. 85-year-old, low syntax score, symptomatic left main disease. No question that it's not an acute coronary syndrome. Stable coronary disease with left main disease, revascularization is a must. The question is, what's the strategy? Antonio, can we start with you? And then I'm sure Dr. Kinney will tell us what her plan is. Just if it's okay with you, Dr. Kinney, just to get this panel's input.
But first of all, I think this is a lucky man.
Did they bring a Puskas on stage or no?
Yes, Dr. Puskas is here. Don't worry. Okay. We're going to go to him next. Good. Don't worry.
All right. And I
got him up here. Okay, Dr. Colombo, go ahead. Tell us.
So I think this is a lucky man because has a really disease confined to the left main with very healthy vessels. I think there is a calcium. There is a lot of calcium. So I think we need some kind of plaque modification. And definitely I see for one stent, this is a typical lesion where a single stent would fit.
Single stent. Okay, interesting. Dr. Puskas.
I'm impressed at the size of the right coronary. It's a very right-dominant system, which protects us in intervention on the left side. It is, however, a trifurcation distal left main lesion, which will be technically challenging. That's outside my field of expertise, of course. This patient could have 3 arteriographs, LAD, ramus, and marginal vessel. But at 85, with other comorbidities, if this can be managed with PCI, I think it's a reasonable left main stent.
Okay. Good. We're in LAD now.
All right, great. Let's hear. Is anyone on this panel would want to send this patient to bypass right away, or would there be this patient go to a heart team? Holger Thiele from Leipzig, Germany. We're so lucky to have you here. Welcome to New York.
Yeah. Yes, thank you, Roxana. It's a pleasure to be here, although it was not so easy to get here. For sure, we would probably not send the patient to surgery. We would also go for PCI. I'm not sure. I haven't seen enough projections so far on the strategy, but maybe Dr. Thiele will tell us on the strategy she wants to do for this bifurcation, left main stenosis.
Dr. Kinney, what's your strategy?
Okay, so initially we did, based on the diagnostic angio, we thought probably there is calcium, but the issue here to IVUS this, to understand calcium is you see there's a TIMI 2 flow from left main to LAD, so I did not want to IVUS to begin with. So just based on angiogram, this is a guide shot.
We'll continue.
There's left main to LAD disease, and angiographically, there's osteal circumflex disease. I understand there is ramus also, moderate size ramus, but I think for discussion point for the PCI, we would not do anything with the ramus. So what I did was I wired the LAD and circumflex. Are you able to see the angiogram well?
Yes.
Does the panel agree
Yes,
that
we
it's
see,
osteal
we
circumflex
see
disease?
the angiogram. Any comments, Dr. Lasala?
Yeah, I'm actually struck by the fact that this is an 80-something-year-old gentleman, and he really has really focal disease.
Yeah.
It's not heavily
said the same.
calcified, so it's very favorable for PCI, and I'm sure the IVUS will be more illustrative, but angiographically, we don't see a lot of heavy disease in that osteal circ, and we don't really see that much in the ramus. So in these kind of cases, less is more, and being able to stent maybe from the left main into the LED might do the trick.
Yeah, Dr. Gibson, who described the TIMI frames, is here with us. And what's your thought about that LAD flow, Dr. Gibson?
Well, it's obviously slow, but I agree. This is amazingly focal, and I'm a less is more kind of guy. I hope just treating that LAD will be effective.
All right. So where are you and what are you doing now? It looks like you're already into the LAD.
So since we did not appreciate a lot of calcium, instead of atherectomy, we said, let's do atherectomy. So we are using 3O flextome into the LAD. Now, if the Wolverine, the question, if anybody concerned, we could probably IVUS the circumflex now. But I think the osteal circumflex has disease, because if there is osteal circumflex disease, this will definitely fall into complex left main disease, which means to begin with, we should decide on 2-stent strategy rather than doing provisional stent. And then we know that the chance of any side branch compromise is high, up to 50%, as shown by a DK5 trial. Good.
Dr. Manesh Patel, I think you're on there. What do you think of this strategy so far?
I mean, I agree with the panel so far.
Remember,
I think, it's surprisingly focal, and I would start by dilating the LAD just to get flow. At this point, I would image the circumflex and maybe the LED with intravascular imaging to make a plan.
Sounds good. Dr. Sharma, you had
and
a
the
comment?
point is very well taken. No, point I was saying is many times they start with the one lesion. Once you open it, the plaque shift and little dissection happens. Now it becomes bifurcation. But so far, and that is the advantage of this atherectomy techniques, that they have opened up the lesion reasonably. It's the 3O? 3O. Yeah. So I think you could go a little higher, but I think it's okay. No plaque shift into the circ. It's okay to stent and then decide what to do. What do you think?
I'm a little bit concerned about that ramus. That's sort of after this, the plaque shifted actually, I think, into the ramus. Bill Nicholson, your thoughts?
I think what Dr. Puskas brought the ramus up earlier. I think these trifurcations, when you have the ramus potentially involved, we don't have a great strategy for this. And I think imaging of the circumflex would be real important to me right now to understand the ostium. But I think the ramus is going to oftentimes an innocent bystander that we don't have great solutions. You end up rewiring and just kind of reestablishing flow. But to incorporate into a complex multi-stent or multi-vessel strategy becomes very difficult.
Yeah, really good point. And now that I see the way the plaque has shifted after you image the circ, Dr. Kinney, maybe your wire should go into the ramus as you stent that LAD just to protect it.
That's good.
Pull back, guys.
Show the IVUS.
Show us the IVUS. Yeah.
Pull back.
Okay, good. We see it nicely, and he really doesn't have coronary disease. Like, look at this 85-year-old man with very, very interesting. I didn't appreciate the ostium.
Get us a 3-5 cutter into the LED.
It looks
3-5 cutter.
Yeah, I think it's free of disease. What does everyone else think? Would you now put your wire
into the ostium of the circ?
Flush this. We're going to need that.
I mean, at this point, the chance of losing that vessel is in the 1%, 2% range at most.
Right, but the ramus, on the other hand, is hanging by a thread.
Yeah, well,
so
we have.
You might want to.
When we have situations like this, we not only put a wire down. Sometimes we actually jail a balloon, and
Yeah.
stent from the left main into the LAD. And if we lose that ramus temporarily, we can blow up the balloon, reestablish flow, then pull it back, redilate, and then go back through the struts to open up the ramus. I mean, you'd like to not put a stent in the ramus. If you have to, you can do it.
Yeah.
I will put a wire in the ramus for sure.
Right.
And I will image the LAD. I mean, now that you have pre-dilated, I think you can do IVUS towards the LAD. And, with such a big right territory, you can even afford to do lithotripsy on the LAD, even if it's the left main.
So what's your plan, Dr. Kinney, now?
We are trying to
Using a bigger 3.5 atherectomy now, and try to open a little more ostium. But yes, the question is, if that is the concern, knowing that there is no plaque in the ostial circ, should we put this wire into that ramus while stenting the LAD left main? I think that will be a better approach. Although this wiring, there's still a lot of controversies. Some people believe it. I'm a big believer. Anu is not that believer of the side branch wiring. I know Antonio has published also that believe in the wiring, the side branches. As a prophylactic, keep it open. I definitely do. As John Lasala just pointed out, many times you leave a deflated balloon in some cases.
So let's hear Dr. Kinney's
see the
strategy.
difficulty
What
for
do you
us
feel?
to advance this balloon is because of the angle where the LAD is taking off the left main. So now go high, 14, 16, 16.
Yeah, I think that's another
So these are
reason why.
new, you can go to high pressure. This is a 16 atmosphere.
3, 5, 16 atmosphere, Wolverine.
Good.
Yeah, now it's good. Okay.
And it's
Take a picture
amazing.
and put
It doesn't
what
sound
size
like your patient is experiencing any hemodynamic compromise with all of this
Beautiful.
work.
Yeah.
Is that correct?
Okay.
Okay,
So actually I know we have created a lot of apps. Now for this symposium, we have released what is called as Bifurcate 3D. 3D means we have all the bifurcation technique we have animated, and that is what we have released. It is free to download. People should download it either from the Google Play or App Store right now. So by the side, since we decided it's a provisional stenting, which is from left main to LAD, again, same thing. I think the question always is which is the side branch and which is the main vessel. Here, the main vessel is LAD, since the side branch would be a smaller vessel, which is a circ. So we will be stenting from left main to LAD. And I think if everybody agrees, we will go with the 3.5. What length you have? 20? Okay. 3.5, 20 to from left main to LAD. I think
So,
16 should be
Dr.
okay, right?
Kinney, are you planning to wire that ramus? It sounds like you feel confident that it will be okay and that you'll be able
Yeah,
to.
no, I think I'll be
wire.
okay there. I would rather have the wire in the circ.
Okay. So let's see what you.
So if we need to know the exact length of the LAD, so I'm coming to RAO caudal. Okay, you want 20?
20.
Okay. We'll use this view. So far, I think ramus looks okay in this view. If it goes down, we'll wire afterwards.
Okay. That's probably because you're like
So provisional
really skilled
stenting,
in wiring.
let's show the animation of provisional stenting from left main to LAD.
Okay.
App team.
Any comments from anyone on the panel? John?
Yeah, I think that the one thing that the IVUS also helps you with is not only the diameter, and obviously you can get a side view of the branches like the circ to see if there's any disease there. But it also, we find more and more that our lengths are off. Our visual estimates of the length of disease
Is off.
is way off. If you were to just say, didn't do any IVUS here, and you looked at this lesion, I think you're looking at saying, I'm going to do a 12 millimeter stent or something like that.
have it.
When you look at this and you can see that that disease extends really to almost the proximal portion of the left
They're
main and well into the LAD, you end up with a 20 millimeter stent.
Yeah.
Are they able to show the app animation in the side?
Oh,
We haven't seen it, but
On the
what's your,
sectoid.
tell us
Sectoid.
what the size and the length of this stent is. And because I
This
think
is
it
a
sounds like you
3.5/20.
did a 3.5/23, is that right?
Good.
20.
20.
20.
520 Promus Elite.
Yeah,
Ready?
good.
Going up.
Okay.
Are you seeing the app animation by the
I
side?
am not. Oh, no, yes, we are. On the side, everybody could see the app animation on the factoid wall.
Good.
Yeah, I have a feeling
So
you'll
now
need
what I would do,
larger balloon for the proximal, most likely, and hopefully you will image that.
so we went up to 14 atmospheres. We will take out the SDS. We'll take a picture. Then the goal is that we will recross. At this time, you definitely have to recross into the circ if you want to. Otherwise, we pot the left main, proximal optimization, and we'll IVUS.
408.
So this is the
408.
Can you do
Picture?
the caudal view so we can see that?
looks good.
I'd like to
Beautiful.
see that
We'll get ready other side.
the ramus is still open, but I'd like
Get
to
us,
see
get us a
how
4012
it looks. Yeah.
for the high pressure. Okay, this is the view, guys. I think it looks good. I would leave everything alone.
Well, you're going to have to post dilate a
No,
little
we are
bit
going
more.
to do the pot. Yeah, post dilate and IVUS it.
So you would
Okay,
not
good.
touch.
So let's put a
How many
rotor wire
people?
down.
I'm a little nervous about that ramus. Anybody else on the panel care about that ramus?
I think the ramus can be improved. I will put the wire in the ramus.
Yeah.
And I mean, the patient is very stable. There's no reason to get
Anyone
good
else
result.
think that flow will come back? Or
Yeah, I was concerned about the ramus from the first shot. I thought, I probably would. I agree with Antonio. I'd wire it and try and see if I could improve it. I mean,
Holger, you're a minimalist. What would you do, Holger?
Sorry, probably do some imaging. Not sure about the ramus as well. So it's not sure, but I would do some imaging with some IVUS probably. Yeah.
Yep.
I think you're going to end up post-dilating, and you definitely want the wire in when you do that.
Absolutely. I
Problem
mean,
is
if
the
you
7
post
already gives
dilate
the
with a
trouble.
4 balloon,
6 is okay,
what's a
good.
big deal to place a wire there?
She's doing it. She's going there now. I can see it.
Okay, wait, now do it. Fluoro save, top fluoro. Yeah, good, that's fine, go.
I'm wiring now. It's actually, it looks like a diag coming off the LED.
Same view now.
Yeah, it's an important one, I think.
Yeah, you really couldn't see the takeoff when you had the disease.
Yeah,
with
now
the
that
osteo
you've
LED.
stented it,
now you
it
can tell where
looks
it is.
much clearer.
So 1.5, well, not yet.
Yeah.
Want to hold it tight for me?
Just 1 second, off fluoro again. Good.
Yeah, she will
There you
wire
go.
it.
One 1.5. 1.5, good.
Nice, AK.
That's okay. Yeah, good. You prepare them.
Okay.
You could switch more to a caudal
You have a
RAO. You see
4012
the
balloon
ramus.
for the.
do.
Yeah, if she
4 or
just
12?
goes in a different view, she'll get it down distal easily.
Without ballooning though. Try. I think it'll go.
So you notice that even after
Putting
passing
a
the
guideline,
wire,
no?
the flow went down, so the
thought we could
room
try without.
is not very large.
Epicaudal.
I see. With the proximal tortuous,
The ostium was only seen well in that view. Now we are going into a small branch.
we can ask. Fine.
See?
Yeah. What is the balloon for the distal LED?
Patient,
And shock wave for which one?
Is there a stain there?
Yeah, it's just I think is the slow flow in that ramus. She'll get it back.
Lesion after the diag, before the tight. After the diag, before this terminal bend.
Yep.
now die. I think the vessel is closed now.
Yeah.
Still there.
Oh, there.
But
Can be a new
Plan?
fielder. I think the tip of this fielder is gone.
yeah. Good. Tell the patient to be little tattle.
So what else you have planned for us
Get
after
us a 2 or
wiring
12
this?
balloon.
No, nothing. Right now, nothing. We do after. We do then only. We
It's
do.
on
Nothing.
2R12 compliant.
Which wire are you using now? What type of wire?
Fielder.
There you go.
No, that's,
We are going to use the exchange length run through, right? To change or what? Or side by side?
Antonio, what's your favorite wire for crossing
Okay.
sense struts?
Yeah.
You know, of course,
check, we are
always
not doing
start with
anything
a
first.
simple
Yeah. Ready?
wire like a BMW, but then I'm still go to a more non-polymer coated wire. And like a miracle, if I have difficulties, I take a very steerable wire, miracle the 1.5 or 2 grams. And then if I really have difficulty, I go to a polymer. But I'm afraid of the polymer because, you know, they always go forward, but sometimes they go in the wrong direction.
Yeah, they always go forward. You just don't know if they're interluminal.
The
Okay,
nice
take another
polymer,
picture
which
here.
is not too aggressive, is the Azai Fielder FC. It's a polymer, but not too aggressive, so it's a good compromise.
You know, I just started using a dual lumen catheter, the Suzuki, where I can slide it over the main wire in the main branch, and then it has a second lumen with an angle to it. So it actually provides you with some backing so that you can push your wire a little bit more
But
forcefully.
that's so expensive. We can buy 10 stents with that wire. With that.
because no, it was okay.
You're
They
right,
wanted us to wire it.
We
No.
kind of throw
No, it's
money all
gone.
over the place.
In some situation, a wire that it sounds not logical, but the Suhoi, which is a very soft wire used for retrograde, if you have a real small lumen,
us,
can cross and go.
Only post-dilate. Maybe it'll open up the ostium.
You have the fighter wire? Fighter. Flow was very good. I think the initial wiring has destroyed the ramus now.
Oh, you put a wire beforehand?
Hmm?
You put wire before? No, later.
We are changing to some other wire. Now going back to which is the wire, I think the wire of choice for us here is always a polymer jacketed wire for the side branch.
Okay.
And you tell
So
us
we
when
have
are ready, we are ready
33
to
more
start.
minutes to this transmission. I know you probably have another case as well.
good.
Is
You
that
go
right?
to room. You should go to room.
Yeah,
two.
we
We are
know
going
you're
to
going to
just,
cross this, but if it's
Post
okay,
dilate.
we'll go to
Yeah,
another
post
room.
dilate it. We are going to post dilate, and I was the left main.
Wonderful.
Good.
Okay.
You know, the message I take is that always wire all the branches at the beginning.
Yeah, if you have to put down 3 wires, you put down 3 wires.
3 wires always, because you never know. It's you know that they will cross, hopefully, but saves you time, make the procedure less.
And then if you've got the wire down, it's okay to do a proximal optimization, and you
With the
don't worry
wire
about the
down, you
branch.
can always
See,
do
that's-
something. If
yeah.
you cannot
That'll make it easier
recross,
to
you
wire.
go with a small balloon over that wire. I mean, it's.
All right. Well, this is okay.
Make sure the main vessel has a good flow. You stabilize the main vessel, and then you go to a side branch.
Yes,
The side
yes.
branch was large enough. If it was like here, circumflex, which we wired.
I
Now you can
agree,
go to room 3.
but I would have wired the ramus before placing a stent on the LAD.
We are ready here.
Case 2.
We are
Let's
to
go for
room 2
case
now,
2.
right?
Yes.
Room 3 means case number 2.
Yes.
On my right side, Dr. Barman, and we have our fellows. Actually, can't even recognize with so many masks and caps, and so Akash and yes, so all the fellows are there along with our cath lab staff here, Twinkle and my cath lab staff, Vicky and Ashley, and so we welcome everyone for this live hybrid meeting, and let's start with the case number 2. which they can show the slide. It's a 45-year-old patient, end-stage renal disease, very bad constrictive, seems to be. You see the pericardial constriction in the bottom. Can you see the angiogram after the? Okay. Yeah, see this now. See the whole question was, patient presented with as a pre-op evaluation as class 2 angina before the renal transplant, EF about 50%, and MPI was indeterminate. So basically, angiogram was done by a few weeks ago. See the calcium in the pericardium, about the constrictive pericarditis, and look at the calcific coronary artery. I would call it is not a severe. It is like a massive calcification.
Yeah.
Not only in the pericardium, it's actually equally bad into the coronaries, and see here. This is the left main, very tortuous LED. And you appreciate that, and this is the money shot, where you can see very calcific, proximal calcium, but good lumen. Then mid about 50, 60. Then distal area about 90%. You can see there, and then there is a diagonal. So all this very, very calcified, right coronary is okay. So question was that does patient have constrictive pericarditis? Patient was brought in. Echo was plus minus. We did a fluid challenge, and hemodynamics were?
It showed concordant LV and RV tracing. So
basically nothing from constrictive pericarditis point of view. And this is all with the CAD, with this lesion, knowing the patient needs transplant. So patient has a surgical consultation. Because of this calcium, we are not very enthusiastic, although Mount Sinai lab is calcific. And the symposium, I thought that we'll soon make it an atherectomy symposium, because majority cases will be done with one kind of atherectomy and other. But this tortuosity, we felt this is a good case. We do also, despite EF around 50%, it's not a classical less than 35, but 35 to 50, enough data have come in a complex CAD that FDA made approved Impella for these patients with the mild LV dysfunction or near normal LV function in a complexity like this case. If perforation occurs, anything else happens. So it will be a surgical, opening the chest will be very, very difficult. So we need to stabilize this patient, and therefore we had done the Impella. Impella basically because of the complex CAD and knowing that our options are limited. This is appropriate from the OC point of view. They can show the slide of the OC on one side. So we are ready here with that calcium, and also it's a large vessel. And that is where our algorithm, we are trying to put it down. Now we always have a good algorithm of orbital or rotational. We'll show you those cases today to our audience. But question is, where does the IVL comes in? IVL, which is recently approved. And this is kind of case, maybe because of tortuosity, maybe just use a small bar followed by IVL for a synergistic. We call it the lithotripsy or so. So basically, this is where we are now. So Roxana,
yeah. So an amazing case. Really.
I mean, by we have wired the LED, a little tortuous, but we are able to do it. This is the floppy wire, and we are ready with a small 1.5 bar. We thought whether we use 1.25 or 1.5, but clearly we wanted 1.5, and we were able to get our fine cross without trouble. If it would have been difficulty, then I would have gone with a 1.25.
So since you've already started this, Dr. Sharma, and you're moving towards that, while you're doing that, since your strategy is set up, first of all, there is an app for this as well. There's called a Calcific Aid, which is an app that Dr. Kinney and her team have developed. As you saw, the Bifurcate and 3D app that was used to help with those of you who want step by step, depending on what the anatomy is. But we have an incredible panel here, and I'll go to John Puskas first. This is a very, very high-risk patient, end-stage renal disease, dialysis, going for renal transplant. Would you operate on this patient with a lima to the LAD and diagonal?
Well, as you know, renal failure is actually one of the high-risk scenarios in which coronary bypass outperforms PCI in general. On the other hand, it is also a group in which we have more complications, more prolonged length of stay, and more morbidity than in non-dialysis patients. This looks like pretty focal LAD disease. his pericardium would be very hostile. That right
Exactly.
coronary injection, you saw a crescent of calcium across the lateral aspect of the pericardium on that fluoroscopy. And I think that's indicative of what would likely be fusion of the epicardium and pericardium, so that opening that pericardium to get to the LAD can be a 2 or 3 hour endeavor. If this were me as a patient, I would want Dr. Sharma to put a stent in my LAD, and I would go home savoring that delusion, which is quite unlikely that I'll ever get a transplant. But I would go home and continue to
We had
savor
a
that
little
delusion.
difficulty. Anytime you advance.
Did you
we
hear that,
advance on
Dr.
the
Sharma?
diagram,
Dr.
to get
Puskis
the
wants you to
possible
put a
cardiovascular-
LAD stent. I mean, like, write this down this day. Dr. Puskis agrees with the team approach. I'll go to Holger Thiele. What do you think about the Impella use here? You think it's an overkill?
So based on evidence, currently there's no indication to do it with the impeller. So I'm not sure. Honestly, I haven't seen the left ventricular ejection fraction in this patient. Probably this can be done without the impeller, but nevertheless, probably it will give you more, a better feeling in this moment if you have the impeller in place.
Yeah. And I think he's planning to do something with the diagonal too, I'm sure, Dr. Sharma. And I guess that's why you chose a very small burr. I probably would have chosen a 1.75. John, how would you proceed with the LAD, and what did you think about first rotational versus orbital atherectomy in a case like this?
Well, I for rotational atherectomy when I have very high grade disease. I mean,
Yeah,
like 90
this is
plus
hugely
percent.
high grade. Yeah.
And or when it's very, very long. So I agree with the rotational atherectomy. I think when it's focal like this, I do favor 175 because it'll eventually get through there. And I've got an impella in place so that even if I have some debris that gives me some LV dysfunction, it'll be well tolerated at that point.
It sounds like you're good with the Impella in place here.
Well,
Would you have put
I
an
think
Impella? Yeah.
For that, probably not. But I think there's nothing wrong with taking that precaution. I don't think you're done though, obviously, when you just do a rotoblader. More and more with these large vessels that are heavily calcified, and you can see that you don't need IVUS to tell you that this is 360 degrees of calcium. You're going to have to do something on top of that. And more we've gone to rototripsy, following this up with shockwave.
Yeah, and we're about to launch a randomized trial called RotaCut in our own institution and San Francis Hospital with Jeff Moses. Dr. Sharma and Dr. Moses are going to lead this by actually following the rotational atherectomy with cutting balloon versus the standard of care. And I think that's an interesting concept. Dr. Sharma, you want to talk about that a little bit?
Yeah, so we'll right now what we're doing is, as mentioned, this is now IVL catheter. 1.5, I mean, I can tell you 1.75 because of proximal tortuosity we are worried about. So we had done the 1.5 burr, we had done any no balloon. And now we are with the IVL catheter. We were waiting whether it will go directly or we need a Godzilla. You can put this through 6 French. Patient has impella, single hole. We have 7 French guide catheter. We can put a 6 or 7 impella. And now we are reaching to the lesion. So question is, this is the IVL catheter. So I know it's a little bulky catheter. Always question comes whether it will go to, I know in the trial, large number of patients. Yep. About 55% require pre-dilatation, but in this case, we have done the rotablation, which are not part of the disrupt CAD3. And now tell us, Nitin has done some cases with IVL, and tell us what we are doing now.
So,
What balloon it is?
So they come in different. The coronary lengths are 12 millimeters. We can go up to a 4. Can you come off standby here?
Yeah. How much is 14?
4
Okay,
atmospheres.
4 atmosphere. Yeah.
Okay. And then there's the button here. So
they should show the
Yes, they're
animation of
showing the lithotripsy.
IVL on the side.
Yeah, we have it. We have it all.
Yeah.
Everything is being shown.
So we're going to do, there's 8 cycles of 10 pulses per catheter. We're running it now. I'm kind of doing it as we talk because I don't want to leave it in this lesion. So that was 1. The lengths are 12. Now you go up to 6 atmospheres.
Okay.
So the pulses are delivered with the balloon at 4 atmospheres. After the pulses are delivered, we go up to 6 to see if there's the dog boning is released.
It's
still there. So now go down to 0.
0, okay.
And then go negative. You got to re-prep each time because some bubbles can get generated, which will decrease the efficiency of subsequent trains.
Okay.
Okay. So go back up to 4.
Okay. We are going again, second.
Okay. So once at 4 again, we'll deliver. This is our second. And the console is pretty helpful. It kind of counts down. So we went from 80
They can
to
show
70.
the console also on one side. Can we bring that to the camera?
So it's interesting. If you look at the EKG, you can see the capture of the sonic impulses.
Yeah.
It looks like it's a pacing spike, but it's actually from the.
Well,
From the
I'm
balloon.
someone who doesn't like rotablation a lot because of the no reflow, and I've really been using this a lot. And
You've been using this a lot and
it's really-
impressed.
yeah, I've been
Yeah,
impressed.
I heard Dr. Colombo is also a fan of lithotripsy these days. Tell us.
I'm a fan in the sense I use it when it's needed, but I think the impeller for the no reflow is unbelievable. We had a case a month ago with dramatic no reflow. The fellow was very fast. Even before giving nitride, he put the impeller in 2 minutes. The no reflow went away totally. Amazing. We're going to publish this case in an image. I never saw in my life a no reflow going away completely.
Yeah, and it's amazing what we can see angiographically. I don't know if those of you in the back of the room, I know that we put more monitors back there for all of you to be able to see. You can almost see the wall pulsating because it's calcific with the lithotripsy. It's fascinating. You see the wall pulsating with the ultrasound waves. Very interesting.
It's still a little dog bone effect, yeah.
Yeah,
The other
it's
thing
still
I would
there.
add is that the balloon is a little distal, but the can you go to 4 atmospheres?
Yeah, we want to pull back a little bit or not?
No, this is what. So the
4?
The sources are 6 millimeters apart, but they're not centered. They're closer to the proximal marker. So there's a 2 millimeter gap from the marker to the first, blanking on the word of the, to the first point. And then there's 4 millimeters on the back. Now go up to 6.
Okay.
So that 6 millimeter segment is not in the middle of the balloon. It's more proximal to the balloon.
Okay. It looks good.
Yeah, so let's hear from Bill. Bill, what do you think about this strategy?
Yeah, I think I'm probably more of a minimalist than most. I think I agree with rotablator and atherectomy that an impella is one place with a fairly normal EF that I would think about doing that if I was going to rota multiple territories or long zones or left main. I would probably not have used protection in this case. It wouldn't have really entered my mind to use protection in this case. But I think the combination of the atherectomy and then the lithotripsy afterwards is very effective. We do it quite a bit, and I think it's a nice strategy here.
Great.
It's like 3.5. It's over here.
Do you image these vessels post in a transplant patient? Anyone want to comment on that?
I'm surprised we didn't image after the rotablator, to be honest.
Mm-hmm.
So I'll show some of these cases later on today.
Trying to get our devices in. So now let me show you the picture. We saw the rota picture earlier. And now we are after the IVL. Let's see here.
But it's almost like magic the way sometimes this melts away just at the 4 atmospheres with the sonic application.
Okay. Put a stent put length after the diagonal.
Can you show us that angio again? I'm sorry, I know you're going in, but... Oh, okay, that's
We'll
fine.
show it, yeah. Good. Right? Yep. Okay, go show the angio.
It looks like they did single access. Did they do that for this case? Did they stick the sheet?
Yes, single axis, yeah. Yep.
And in
Yeah, this is the one after. So before the rota. So with the rota, just with the 1.5, this was the lumen here. This is the lumen go. And the key is that IVL has really made a difference in this combination strategy. We still need, I can tell you, without rota, this device would not have gone. So now we have what we have now.
Yeah. This is a 3515 NC balloon.
Okay, 3.15 at 20 atmosphere. Let's see, we opened it up. Yes,
So do you
it's
have
open
to,
nicely.
Dr. Sharma, do you have to cover the entire length of the lithotripsy balloon, even though your lesion is focal? Would you use a longer stent to cover all of it?
There is a lot of lesion after the diagonal. So I think we should cover just after the diagonal and then work on the diagonal later.
Separately.
Yeah, separately.
I go 23, or we'll take a picture here.
Or longer.
Yeah.
Or 28.
One more here.
Yeah.
Right after.
28, no?
Yeah, 28.
28.
Good.
I'm
Okay.
surprised you
That's the-
didn't
that could
use a
cause some
longer
problems.
stent to begin with, or have you?
No, longer we are going to use it. We have 28.
This is just
Okay.
the pre-double.
Yeah, this is a balloon now. I would have used longer balloon. That is 100% correct, Roxana. If
Okay.
I would have been in the room, I would have selected 3.5, 30.
Yeah.
But that's okay.
This is fine.
15. Yeah, let's see. Yeah. Good. So far, so good. What the angle? Do you want to go after that angle? Yeah, that angle. After second diagonal.
I'm not sure if the balloon's going to go here. Let me just.
No, but we had to open there.
Yeah.
We had to put a stent there.
We haven't dilated this? Yes.
Yeah, we are not. Okay.
So you're going around the bend
So that
now. Really?
Band. I mean, of the multiple bands we are talking about, good. Pull back a little bit. Yeah, good. Yeah.
The
28
focal
will be okay or
lesion becomes
33?
a pretty long one.
33.
33.
Yeah, have a guidezilla on standby, please.
Yeah, 3.5, 33. We are using the Zions
Sky Point.
Sky Point, the new, they keep changing. Every month, Zion's family, they come with a new.
Even in our place with such a long lesion, now we will do IVUS, and if the result is good, the lumen, we will do drug-coated balloon and no stent.
Oh, wow. No, not in our place.
Maybe not a Colombo. Will that not be on the small vessel or even in the large vessels?
Even in the large vessels, we have a study being launched soon, 3,000 patients. I don't agree for short stents, but for long stents, I think is interesting.
Any comments from Manesh and Holger? Manesh first, Dr. Patel, and as they're putting in, what do you think about the?
It's a great. I mean, I think it's amazing result so far because it was so calcified. I think I'm a bit of a minimalist who may not have had the impella, but it's made it look really easy. I do wonder as they come back what the strategy on the diagonal will be, and it'll be interesting to what the group thinks about that.
Diagonal will require a small rota bar also.
It's going to have to pull back here.
1.25.
Seems pretty calcified and likely needs that therapy.
Yeah. So and we had to find out that we'll go offline. And I think if Anu is ready in the next case, knowing that we want to be in time, are they about ready there? In the third case, they had done the retrieve the side branch already. You can pull back few millimeters.
Yeah, longer stent. Yeah. You might need a second stent. Yeah.
Good. But that's good.
Yeah.
Yeah. Good. Ready? Okay. 3.5. This is with the tortuosity calcification. This is the sky point. That is deliverability. Yeah.
So we're 13 minutes for this transmission. Tell us what's your next strategy here. You're gonna do this. You're gonna image, then you're gonna go to the diagonal. Is that right, Dr. Sharma?
Right. So
With the same burr?
Get a 3.5. 15. So what we are going to do is wanted to show you the results here. This is the key. Where the money is. This is the money shot. And we take a picture. Then you go to the next one. And so the strategy is very clear. We are going to open that LED stent a little further with a very high pressure 3.5. And then we come back. Then we go to the diagonal with a 1.25. Patient is tolerating. Clearly, it was all dependent on how the patient behaved. So far, patient is behaving okay, but they become restless. We had done the money shot already. Beautiful.
Very nice.
All right. With
Okay.
that complexity, we are able to finish here. We'll go to the diagonal in a few minutes.
Okay, so the diagonal
And you
should
can
be
do the next
simpler.
case, yeah.
Hopefully, you just do a rotational roto stent, and you'll be done with that. Let's go to Dr. Kinney. I'm sure she has a lot to tell us. Dr. Kinney.
Yes. Are we showing live case number 3 by the side?
No, we're showing, we're going to start number 3, but we want to hear about number 2 first. Number 1 case, how did you end up in the other room? Case 1.
The flow of the vessel came back. We just left the vessel the way it is. Yeah.
Okay, good. And you IVISed and all looked good in the left main.
Yeah,
So just
yeah.
a single stent to
Yes.
the LAD. Excellent. Okay, live case number 3.
This project.
11 minutes. Let's
So
go.
if you can see the live case number 3,
Yeah.
it's a 67-year-old male who had initially presented with positive stress, stable angina, had a CAT, 3-vessel disease. His other vessels, which were RCA as well as a circumflex intervened. He has a lot of risk factors here again, hyperlipidemia, diabetes. And now here he is for, LAD diagonal bifurcation. Just want to show you the entire angio. This is a PDA.
Oh, wow.
EF is good. PDA stent is okay. Circ stent is okay.
Okay.
So mid LAD, actually bifurcation D1 and D2.
Very interesting. So it's a double bifurcation. I'm sure there's an app for that. But before we go to your app, tell us what you're doing. It looks like you're doing OCT or imaging or whatever you're doing. What are you doing?
Yeah, we tried to do OCT. The calcium, I think, was not allowing. That's why we synate that amount of calcium there. And I think a tight lesion, the catheter would not go forward.
Okay.
So we change, this is a calcific LAD. So instead of atherectomy, we're going to atherectomy. This will be orbital atherectomy here.
Okay.
Now you can ask the panel how would they otherwise tackle.
So here, though,
we changed to Viper wire.
Okay. So it looks like you're doing
and we're
orbital
ready to do
here.
the atherectomy.
Let's start with John Lasala.
Yeah, I started to make that discrimination early on about what I do with rotablator, what I do with orbital. This is a better one for orbital. It's not like this heavily calcified super 98% lesion that has a great deal of length to it.
And there's no angulation. It's kind of a straight
Open the wire.
shot, right? Because
Right. So
I
this-
worry about the angulations with orbital. Does anyone else have those concerns or no?
I worry about angulation with any one of them.
Any of them, yeah, of course.
Orbital actually does a little bit better with some of it.
Uh-huh.
Yeah, rotablator's not. Rotablator, of course, will gutter if it has a severe bias, right? So it won't go through the lumen that you see. It creates its own lumen when it has a severe angulation because it is spinning at a much higher speed and has a lot more power. Orbital kind of will adjust a little bit more and accommodate those bends. So it actually does a little bit better, I think, in those situations.
Yeah.
This is a perfect one for orbital.
Dr. Patel,
Yeah,
your
I
comments?
was going to agree with that. I think I would think about orbital in this scenario because of that. And then I just as you said about angulation, I think the other thing to think about is the speed of what you're doing. It's not the rotablator speed when you do orbital. So it does deliver and do it, but you have to just go a lot slower than.
And it's kind of doing it as you go forward and as you come back.
So the advantages are you can use it going forward, going back, and you can go slower, and you have flow around it. But I would say I haven't seen an appreciable difference in no reflow.
No.
Yeah, I think you see in our lab, we're very proactive about atherectomy, use of atherectomy. I'd love to hear from Holger. I know that in Germany, you guys are not so into atherectomy, or maybe you are. I don't know. Tell us.
Yeah, no, we are also active with atherectomy, but we are mainly using rotablation because we currently still do not have the orbital atherectomy in Germany. So it's one of the few things where the Americans are faster than the Europeans. Kidding. Probably for this page, we would also go for rotablation.
To that tight area.
Bill, you
no
said
calcium.
you're a minimalist. What would you do here? Would you do orbital atherectomy, or would you just go with atherectomy or lithotripsy? Or
I think imaging would be nice to understand exactly how much circumferential calcium you're dealing with, but we would probably lean towards just rotational atherectomy with a 1-5 burr.
Yeah.
So slow.
all right. So
we're starting with the orbital at 80. We have very good reflow on the left main, so we wash out all the embolization.
Can come out.
And we did it at 80 speed. So
Start coming out.
we did 2 runs, 30 seconds in between, and we're removing the orbital. Now let's take a peek.
Now, if we were able to image, depending on the amount of, we can show the calcificate by the side, based on the imaging, how you decide which atherectomy you want to use. Actually, what we showed, if you have severe calcium, which is more than 3 quadrants,
This is the run through wire.
OA works better.
okay.
What we showed that if you have moderate or mild calcium and there is presence of fibrous tissue, lipid in the other quadrants, that is the time when you see that it causes a gutter. Because this actually causes cut and causes gutter. So it's very important, yes, like mentioned, that imaging, if you need to decide which atherectomy device you want to do, imaging is important, like we tried here. But since the imaging catheter would not go because of the amount of calcium and severe stenosis in the LAD, we made a decision based on the angiogram.
So will you image now, or will you proceed? What's your plan?
Not now. I think look at the flow. Yeah.
Better.
Okay. So now
And
you
see
just
that,
want to proceed.
this is one, that's a wire of the orbital atherectomy wire. There are two of them, wire advance,
Filter wire.
flex wire advance, and the floppy. So basically, you see the little gutter has been created in the angulated lesion. And so this is one thing we want to avoid. And of course, you need to worry about the perforation and so. But here, so far, as long as within the gutter, many times, in those cases, you may have to exchange your wire. Usually we go side by side, but if you have created a gutter, it's better to go with the over the wire system you already have, which you used to begin with, and so that you remain in that lumen.
Yeah, because I see a little bit of.
But anyway, so always we go side by side, like other side also. We went in that LED side by side.
Good.
You see a little dye?
Some dye, or we have to go with the fielder fine cross, right?
I think this is the case with the nothing.
Yeah, get me the fine cross.
Leave it in the diag. Leave it in the diag.
It's actually going to the D2. This, I think we may dissect.
Let's
the
exchange
vessel.
with the fine cross.
Okay. Get the fine cross?
Yeah.
Yeah, this is another teaching point. So for a lot of our audience,
safer.
So they always say that, do you need to change over the system? I would say that if you see any gutter, you see any dissection, then it is better to see, like in this particular case, you see that you have created that dissection
there's
channel.
definitely a dissection
Which is good.
proximally with this,
Yeah.
you know.
Yeah, exactly. So I would say in atherectomy, the dissection is your friend. As long as you don't lose the lumen, don't lose the wire in the lumen.
300 run through.
So this is what we are going to do now. Fine cross, change to the 300 and dilate with the balloon. And then I know that we are on the time today. So in next 2-3 minutes, we are going to end this case and you go to your very important the revascularization guideline session.
Yeah,
and we'll update you. Just to say on my side, LED was so good, so we did not do anything to the diagonal. Anu, you want to say now?
I'm actually quite interested in this case, just to see how you proceed, especially for those two diagonals, whether you'd be wiring them beforehand and all of those things that we talked about in the first case. But your Bifurcate app will tell us otherwise, but I'd like to just know how you are proceeding. So now it looks like you're going over the wire.
So first goal is to stabilize the LED. We will get the wire into the LED. Like we mentioned, I tried side by side, could not do it. Then we use the same fine cross. And now I'm using a long 300 wire to wire the LED.
Yeah.
Too much mag. And then what we'll do is wire that diagonal. Now, ideally, we want D1, which is a larger vessel. And I think in this particular case, we will leave the D2 alone.
That's good.
So at the risk again, Antonio brought up of driving up the expenses. This is actually a good spot for a dual lumen catheter. So you don't have to traverse that dissected plane a second time.
I know that we're going to.
We already had the fine cross to use in the beginning, so you just use the same catheter.
Dr. Puskas.
I know we're going to have a discussion of indications and revascularization guidelines. The presentation of this case was quick, and I may have missed it, but am I correct in understanding this is an otherwise healthy 67-year-old gentleman with 3-vessel disease and diabetes?
Yeah, I think that's correct.
Was there a heart team conversation about the Freedom trial and his outcomes, and what will we expect his survival to be relative to a coronary bypass?
In this case, there was only LED diagonal bifurcation. Other vessels are less than 50%, 30 to 50. It was single vessel LED diagonal bifurcation with a syntax score of 9.
No, that was PD and OM.
I'm sorry, what?
There was previous stents in
that
the
had been done before. That time you had a discussion, right?
Yeah.
He did have a discussion before at 3-vessel disease when he was 3-vessel disease diabetic, and it was decided the same. They were spot lesion. I think that's what we need to revisit. Very important that yes, diabetic 3-vessel, but this guy had spot lesions, and during the discussion, patient wanted a PCI. So that's why in the first sitting, the OM and the RCA was taken care.
Yeah. But very important point that heart team discussion has to be outside the room with the surgeon, cardiologist there. Then only it is validified, because on the table, the threshold going for intervention is very high, so it has to be outside, and that was done in this particular case. And you're right. So now it's the residual syntax score was 9 only. That's what left here. And so having the main part done after the discussion, 2 spot lesions, right? Both of them were taken care with the 2 stents, short OM2 and RPDA.
Yes.
And here for LED diagonal bifurcation. But yes, there are 2 diagonals, the second diagonal is small. I think just take care of the main one, and then you decide whether mini crush, likely mini crush, right?
Yeah,
so that they can go on the lecture. So tell us what your strategy is. So,
because
Roxana
we
can
want to
take,
go
for
straight
next
to the
session.
lecture,
So
and
we're
I'd
going
like
to pre-dilate the
keep our
LED.
panelists.
Going back to the same point, in this particular case, I think about bifurcation. You know, for people out there, we have to know bifurcation all depends on the side of the, size of the side branch. The size of the side branch, the disease of the ostium, and the length of the disease in the ostium. So if you go into this case, the LED diagonal is same size, is a 80% lesion of the side branch, and the length of the side branch is greater than 10 millimeters. So taking everything into account, to begin with, this has to be a double stent strategy. So we will pre-dilate the LED, then we'll pre-dilate the side branch, and we will use a mini crush technique.
Okay, so please, fluoro save everything, because when you come back at 11:15, I'm expecting to see the final results of all 3 cases very quickly for our audience. They're all eager to see. There are some questions also. Please feel free to send your questions to me. Most of them have been addressed. Some have to do with side branches, etc., that we'll discuss again. Thank you. Thank you, Dr. Kinney, Dr. Sharma. We're going to go now.
Okay, good. I have the entire cath lab team behind me here who have helped me with that case. I have Dr. Moreno who was with me in that case. So if you can show the angiogram, are you able to see the angiogram?
Yep.
This is where you left us, that we wired the main LED. Then we wired the diagonal, and this was just a balloon. If you see here, after the orbital atherectomy, 2.75 20 balloon, good expansion. We did a cutting balloon of the side branch. This is what it was, and I think I did mention, since the diagonal was a large size as the size of the LED, we did plan 2-stent strategy, and we did mini crush technique. If you see here, it was a 2.5-28 in the diagonal and a 2.75-33 in the LED. All the steps. So this was the final result. Now, we need to recross and kiss. But especially when there is calcium, we do face this problem. That even though I was able to wire, no balloon would go into the side branch. So what you do in that, if you see here what we have saved, if you can actually see it, is a 1.25 balloon. And what we call this is a balloon anchor technique. You go 1-to-1 balloon size to that LED or the main vessel distal to the side branch, go high, about 10-12 atmosphere, and then you get into the side branch. You see, this is the fluoro save. Are you able to see how I was able to get the 1.2 balloon into the side branch on the fluoro save? You can see
it. We saw it. Yeah, we see it right there.
This is called a balloon anchor technique, which is very helpful when you have calcified, or bifurcation lesion like this. We went, then we did a kissing balloon. This was the final OCT, and he will take over now. Pedro?
Okay, so we're going to play the OCT. We're going to start from the distal reference. You see that, you see the position of the stent. It's pretty good. This is after the diagonal. We see no malapposition, and there is very little disease there behind the stents. We see some narrowing now. There is a side branch, and very early we're going to come to the bifurcation zone. So the bifurcation zone is going to show right now. So stop it there. Go further in. Okay, so this is what we are looking for. We're looking for the double lumen, like a neocarina. So if the mini crush is properly done, you will have struts creating a new carina. So this is not malapposition. This is just a double lumen. You see the stent in the main branch, and you see the actual area in the side branch. Just keep coming back. And then we're interested in looking at the proximal segment. You have some plaque protrusion. There is a little dissection at 3. Coming back, we still see the double lumen. And now this is the prox LAD. That is a much larger vessel. We're still in good opposition. And this is the reference that we have a little dissection. So in order to analyze this OCT, you can actually create a whole segment, or you can divide it into 2, because the proximal reference area is 6.2 square millimeters, and the distal reference area is 2.8. So if you apply the formulas of the 95% of your MLA, you're going to be distracted. So you divide into 2, the proximal segment and the distal segment. So if we divide the proximal segment with a proximal reference area of 6.21, we have a proximal MSA of 5.87, which is 95%. Over 95% is optimal. And if you go into the distal segment after the diag, we have a proximal distal reference area of 2.86, with a distal MSA of 3.41, which is 119%, which is pretty good. Now let's present the slide that I have.
Please show the slide.
Yeah, just one slide, very briefly, because I think Dr. Prati did this classification that I think is very important for us when we use OCT to evaluate suboptimal stent deployment. And there are 5 parameters. One is the edge dissection has to be more than 200 microns. We actually measured both dissections here, and there was 112 microns, so it's below. You can show it there. It's below the 200 microns, so you don't have to do nothing here. We also measured the actual stent protrusion, plaque protrusion, that it has to be below 500 microns, and here it was 200 microns over there. So very nicely measured. The plaque protrusion is 200 microns, so it's below 500. You don't have to post-dilate, nothing here. And the areas that are 4.5 distally, we have actually 5 point plus in the proximal, which is okay. And there is no malapposition or incomplete expansion. So this is optimal stent deployment. I have to say that if you don't do this, 31% of your cases will be suboptimal stent deployment. Just to let you know, I mean, that there are trials going on for this, like the Illumine 4, in which this protocol is applied.
Wonderful. Well,
thank
this
you,
is a
Roxana.
great
Any
result.
questions
Thank
we
you.
have?
Thank you so much. I think the only there's
Okay.
one. I don't think there's a question. Maybe Dr. Kwan, did you have a question?
Yes, this is a nice case. Dr. Kinney, Dr. Moreno, congratulations. The reason the 1.25 balloon cannot cross the side branch, do you try to rewire the Y first, or you just go into the anchor balloon technique?
We rewired. We rewired twice. Very important point, by Dr. Khan is the same thing. Is that if you are unable to cross balloon, first thing you do is rewire. Then people do say do a pot, but pot is very important if you cannot wire. That means your proximal part of the stent is not well opposed. So pot is important if you cannot rewire. If you already rewired and the balloon does not go, you go to a different cell strut and then go with the same balloon. If it does not, anchor technique with a lower size balloon. All these steps described in Bifurcate 3D and Bifurcate, original Bifurcate app. Thank you. Now go to room 6.
Wonderful. We need to go to room 6 now. Thank you, Dr. Kinney and team. Beautiful representation of a great bifurcation case.